Good evening and welcome to our special web series on Liver Cancer Awareness Month. I'm Anisha Nair Dhawan, your host for the evening. Globally, cancer is the second leading cause of death, accounting for approximately 70% of mortalities in low and middle income countries like India. In fact, in our country, more than 11 lakh people are diagnosed with cancer every year, and about 6 lakh patients die due to the disease annually, which is the second biggest cause of death in our country after heart disease. Now, hepatic cancer has become a white elephant that everybody knows about, but nobody speaks about it. Liver cancer is emerging as one of the fastest spreading cancers in India. India sees about 3 to 5 cases of liver cancer per 100,000 people, which translates to 30 to 50,000 new cases per year. It is, however, likely to be grossly underreported as India's population-based data is sketchy due to limited coverage of systematic cancer registries in the country. Considering the incidence of hepatitis B here, the number of liver cancer patients definitely does not reflect the real picture. So given this setup and this environment, the Integrated Health and Wellbeing Council, a not-for-profit organization engaged in health and well-being of citizens, is glad to host the Liver Cancer Awareness Month, a live session powered by Lupin Oncology. The objective of this summit is to raise awareness about the disease and bring domain experts and professionals together on one platform to make the general population and patients aware and conversant about the subject. Today, we will be discussing coping and maintaining the quality of life for patients with liver cancer. To discuss this and the increasing incidence of liver cancer in our society and its management, we have a panel of experts joining us. Please welcome Padma Bhushan Dr. S.H. Advani, Director, Department of Medical Oncology, Jaslok Hospital and Research Center, Mumbai. We also are happy to have with us Dr. Shailesh Srikhande, Head of Division Cancer Surgery and Chief of GI and HPV Surgery and Deputy Director, Tata Memorial Hospital, Mumbai. We have with us Dr. P.N. Mahapatra, Director of Medical Oncology, Apollo Gleneagles Hospital, Kolkata. And we will also be joined very shortly by Dr. Lalit Mohan Sharma, Senior Consultant, Hematologist and Medical Oncologist, Department of Medical Oncology, Bhagwan Mahavir Cancer Hospital, Jaipur. A warm welcome to all of you gentlemen on this show. Thank you so much for being with us. And really, we must tell all our viewers that these doctors are incredibly busy, but they're here taking time out for this very important subject to create more awareness and to understand how the quality of life of patients suffering from cancer can be improved. Let me start with you, Dr. Advani. When liver patients seek treatment and are treated upon, what is the most important criteria about the quality of life that gets impacted? It may not be because of the treatment, it may be just because of the disease. What is the part of their life that really gets impacted?
The most important thing that happens to them is over a period of time, slowly they get weaker and weaker with the loss of appetite. So that's a typical picture of patients with liver disease, with a cirrhosis. So apart from this, of course, while they are having the cirrhosis, they also have the sometimes water collection in the abdomen, distension of abdomen. So cirrhosis is divided into two parts. One is compensated, where patient has almost no symptoms, and decompensated when you have the distension of abdomen, swelling in the feet, loss of appetite, loss of weight, weakness, and that's how they progress.
Right. Dr. Shikanda, you operate on a lot of patients who come to you with liver cancer. Now, for those patients who can still be operated, because this is a complex issue, and sometimes operating is not feasible. But for those who come for treatment and who can be operated upon, uh, what is in their mind when they come to you? Are they worried about the surgery? Are they worried about how their lives, the quality of life would get affected? What do they, tell you when they come to you for the surgery?
I think when they come to us, it's always a multidisciplinary decision. And the fact is that they come with a thought of cancer first. So,
Mm,
more than surgery, their clear thought is that they are dealing with cancer.
mm,
So, the first fear is not just of the patient, but the whole family that comes to you with a cancer. But now, in bad news, you need to see what good news you can give them. And the key is to tell them what is possible and what is desirable in that particular individual patient.
mm,
So, if they're getting surgery, surgery is offered only when the tumor is localized to the liver
mm,
and in some parts of the liver. It can't be all over in the liver on the right and left half, then we can't operate. But if it's localized disease where they get liver surgery,
mm,
they understand that in expert hands like ours,
mm,
we would have a rate of people developing complications or losing their life to only about 3 or 4%. That would mean that about 95 to 97% of people will get a safe liver operation. The vast majority of them will be out of the ICU within the first 48 hours after surgery. And within a week to 10 days of well selected cases of liver resection, they have a chance for a long term survival, if not a cure, in that group of patients who get liver cancer surgery. And that group is about 25 to 30% patients. The remaining 70% will get multidisciplinary care, but
mm.
not necessarily a chance for a cure.
So, Dr. Mahapatra, how can the patient or the caregiver be given information about well-being and the quality of life? Because, like Dr. Srikhande mentioned, the surgery is an option for 20 to 25% of the patients. The rest of them, which is 70 to 75 of them, will have to be managed with treatments with the intent of prolonging their life. But you also want them to have a good quality of life. So, what is it that you will explain to the patient, and how will you help them, maintain their quality of life?
See, hepatocellular carcinoma, there is two part actually. They actually first part is they are the liver disease itself, and second is cancer actually, and third is the cancer treatment. First is the liver disease. What is the condition of the liver disease? Actually, we see we have a classification system actually. Either it's a liver condition is good, it's a like layman term, it is a, or it's a bad. If it is a bad, we don't give any oncology treatments. We just give supportive cares, which will be more of a gastroenterology related to decrease the uh, fluid in the abdomen, to decrease encephalopathy, what we cause actually the liver affecting the brain, those things. That is the first part of this. Yeah. Second part, actually, they will be very emaciated. Because of cirrhosis, they are usually very emaciated. We have to see about the feeding part and what will be the drugs to be given. Actually, sometimes we don't give aspirin here actually because of it increases the fluid collection. And the second part is the cancer. Cancer is whether it will be, it all depends upon the liver condition also. If it, treating a cancer is also, you need to see the liver condition, whether the how bad is the liver condition. We call this child book score A, B, C. And if it is a good condition, and the stage actually, if it is a localized disease or is a multi tumor in the liver, or there is a portal vein thrombosis, or liver tumor is coming out of the liver. And
Mm,
actually third is the treatment part in the oncology. Actually these treatments, if we go about these are chemotherapy resistant. We usually
mm.
give targeted therapies, and targeted therapies is very toxic. We have to explain everything actually. You have to start with the liver condition also, patient's disease condition, and if we give any treatment, and the cost of treatment also, that is very important nowadays because of lot of immunotherapy and bevacizumab coming into picture. The cost of therapy, that is very important for the patients actually.
All right. So, a lot of counseling is given to the patient when they do present themselves for for treatment. Dr. Advani, Dr. Mohapatra mentioned that they cannot sometimes be given aspirin as a pain management tool because their eating is impacted and they emaciated, and an aspirin may be dangerous. What are the other things that the caregiver and the patients have to be careful about when treatment of liver cancer is underway, especially when the reason for the liver disease could be hepatitis disease or hepatitis virus?
Yeah, I think as far as the patient is concerned, whenever you are giving any treatment, whatever treatment you have decided, the most important thing is to give him the encouragement to go forward in the life. They should be really, kept alive. That's the most important thing. You have to keep them alive. If you tell them that you are bad, you have to sit in one room, oh, they are miserable. You have to keep them alive. I tell them that continue your normal work. Don't worry about it. Even if you are tired, go ahead and get going in the life. Do whatever a normal person is able to do it. You have no limitation, whether it is in terms of the walking, moving, exercising, whatever you can do, go ahead and do it. Whatever you can't do it, anyway, you will not do it. So I think that's the best way to tell them. Second thing is about the diet. They have to be liberalized in the sense that tell them eat everything. What is food is not toxic to the liver. Food is always good for the liver. So, but give them some advice, and maybe they should take high protein diet and try and maintain the calories. So they should not go down in terms of the weight and all. So these are the few things which have to be advised to the patient. And of course, the caregiver has to almost have the same approach in terms of telling the patient to feel normal. I think that there's nothing like telling the patient that you are still normal, you can do whatever you want, you can eat whatever you want to eat, and there's zero restriction as such.
All right. Dr. Pani says that cancer patients should be encouraged to lead lives in normal fashion as much as possible for them. Dr. Chikande, after a surgery's happened, what is your advice to your patients for those percentage who can undergo a surgery, and also liver transplant as an option of treatment? How successful is that in case of liver cancer?
So I think more than giving advice to patients after an operation, it's important that they are extensively counseled before an operation. Dr. Mahapatra already told you about the various staging systems which are available. And one is, of course, the child staging, which is A, B, and C. If you have a patient who is in stage C, the chance that they are going to end up with a liver resection is highly unlikely. If at all, they may be candidates for liver transplant. But without going into the details of this, there are other criteria as well, like the Barcelona liver clinic classification and liver cancer classification. And they are also important, and they need to be integrated in our decision-making algorithms. Now, we all need to understand when we talk with an individual patient that the liver is the biggest factory of the body. So, and it has got enormous reserves. So even when a liver is damaged 30%, 40%, 50%, 60%, the patients may not have any symptoms. And Dr. Advani is very right that you need to give them the confidence that they have to go on. Even if there is a problem in the factory, there is not a complete shutdown in the factory. There is not a complete strike. And the factory can still be productive enough to carry on with meaningful activities. There would be certain do's and don'ts, and all this needs to be integrated in our decision making prior to surgery. Because, for example, if a patient is going to continue to take alcohol, which is driving the liver cirrhosis, then the best of surgeries will have a bad outcome in the post-operative period. Cirrhosis is nothing but liver becoming very hard,
Mm.
either due to hepatitis B or C or unknown forms of hepatitis or drugs, medications, what I mean is, or alcohol, which is a poison finally.
Mm.
And anything, so we will have to have certain correctable factors pre-operatively which we want to correct. If there is hepatitis B and C infection already of many years standing, we will have to do the viral load. We will have to check that everything is okay. There is no active hepatitis ongoing inside the liver when we offer an operation. So it's about selecting the right case, optimizing the right case, and then doing the liver operation. But actually speaking, well done, safe liver surgery, they would hardly have any issues as regards quality of life post-operatively, because liver is one of the few organs in the body which regrows within 3 to 4 to 5 weeks after surgery. And I told you, if you have 30% of good quality liver functioning, a human being can survive reasonably. Livers which are perhaps 100% working. So we are in peak optimal conditions, but with 30% also, you can have fairly good quality of life. So even if we do large operations and large liver tumors are removed, the remaining liver for the first 2-3 weeks, they are a little weak. They need their confidence to come back. Often there would be a big cut on their belly unless we have done it by robotic or keyhole surgery, which is not always possible for large tumors and difficult liver cirrhosis. In those cases, it takes about 10 to 15 days for the cut on the belly to heal well, for them to regain their confidence that they have undergone a life-threatening surgery and they are fine. But in about 3 weeks' time, the liver is also functioning well, the appetite comes back, and they have a very good quality of life in well-indicated patients. That's the first part of your question. Your second part of the question is a more extensive answer, and that's liver transplant. So I told you, it's not just the liver tumor in the liver, it's the quality of the surrounding liver. As Dr. Advani told you, it's about the free fluid or the fact that they might develop abdominal distension, or there will be nutritional compromise, or they develop a condition known as portal hypertension. It means that because the liver has become very hard, the blood from the intestines, which is to flow back into the lungs and going beyond the liver, it doesn't flow back because the liver has become very hard. So there is pressure, there is blood pressure in the intestines, and they can rupture and cause bleeding. In these kinds of patients, you actually require a liver transplant. So you not only remove the liver tumor, but you also remove the bad liver so that the patient has a better chance to live. But there are certain do's and don'ts. Not every patient of liver cancer is suitable for liver transplant. In fact, very few patients of liver cancer can actually undergo a liver transplant following certain criteria known as Milan criteria or UCSF criteria.
All right. So, liver transplant is, a lot of criteria has to be considered, and it's not an easy way or the only way out for those with liver cancer. Dr. Mahapatra, you spoke about avoiding aspirin, but you said the patients are emaciated. Now, whenever the liver isn't functioning well, the first thing that happens is that you don't feel like eating anything. Your appetite gets completely depressed. So if you don't feel like eating, then how does, the quality of life is not going to be good. How can that be helped when, you're treating patients with liver cancer?
Actually, what happens na, there is supporting medicine. There are supporting medicines. Actually, they have their limitations. Actually, what we use diuretics to, if there is a fluid, we remove the fluid. Once the fluids are removed, they will again, because the pressure is removed, they will have the appetite. We try to give less salt because if you give more salt, they will accumulate as a fluid. We give laxatives to have a good stool so that they will not feel better and there will be no encephalopathy. And we usually advise small frequent feeds, actually small frequent feeds. Actually there is really no medicine that you will give, and that will be. And we live on a tumor directed therapy. If it is a tumor which is causing the problem, you can give some tumor directed therapy. If it is a local, like if it is a liver condition is still good, then you can give some tumor directed therapy which will decrease the tumor and they will increase their well-being.
Okay. Dr. Advani, these targeted therapies, help prolong the life of the patient as well. During this time, what is the best way to manage the quality of life also? Uh, because, there are cases of pain, they have no appetite. And though you're saying that you encourage them to live life in a normal fashion, what if they feel overwhelmed with their condition? Then what is the recourse?
I think the most important thing, which when you give the treatment, is to make them one very important factor is the pain free. Pain is the main, which can denature the human being. The patient has to suffer pain 24 hours. That's the it just denatures the person, and therefore total pain relief is the main function of all of us. That we have to give them a pain-free life, whatever life they have got. So that's the most important part of the palliative treatment, that keep them pain-free. And for that, you can use all the things, all including right from the simple painkillers, but mostly very soon uh, uh, morphine and opium related drugs, which we use it, and we don't compromise on that. There's nothing like, people, the relatives are afraid of using morphine. We are not
Yes.
afraid. Relatives say, oh, morphine. They feel that patient will get addicted to the, but I've yet to see the addiction with the morphine. So you can see that how the perception of the patient and the relative towards morphine is very different. And you have to really educate them that you should not suffer, not try to bear the pain at all. Make sure that you are pain free for 24 hours. That's an important thing that you have to teach them. And that's what even the WHO recommends. So we really, that's why there's a controversy about marijuana. It's all because that why some people feel strongly to use this for medical purpose is basically because it gives a very elevation, it improves the appetite, it improves the well-being of the patient. So there are large number of the patients who are in need of marijuana, and all over the world it is being legalized now. Therefore, I'm sure even in India, the time will come that it will be legalized, and then we'll be able to use it for the particular patient to elevate the mood, to make them eat better, and to live a good life in such a situation. So I think that is one of the most important things. Second, I think we have all discussed about the diet, which I think is very important for these patients. The only way is to use maybe marijuana. I use it, marijuana. The patients, they bring it. From where they bring, that is none of my concern. But they bring it, and I say, you better take it. And you should see them, how happy they feel. They're very happy with that. And they are eating, they feel better. Some of our patients go to office. And so it's a real joy that how they start eating in this situation. So I think basically the palliation is at that level. Of course, when the patient is under treatment, that's the time you have to just guide them that what are the things that he likes the most, and he should take it. Because who puts the restriction on diet on the patient? Not doctors. Doctors never put the restriction. The patients relatives, anybody who comes over there tells them, please don't eat this. You have a liver disease. Don't eat fat. Don't eat this. Don't eat that. They put the restriction, and poor chap ultimately what is he getting? Some very sort of a diet which is totally unpalatable. Totally unpalatable. They call it dudhi. I do not know from where they get these things, but they call it. So the poor chap, morning, evening, night, is eating dudhi. Nobody can eat that. So
And that too with less salt.
no salt, no fat. They say no fat, no ghee, nothing. So I think these are the myths which are in the society, and they have to be
You
removed.
need to dispel them, because
That's
this
right.
is what is actually impacting their quality of life, and they can't eat what they want.
That's right.
It's not fair, whatever treatment they take. Dr. Mahapatra, Dr. Arpani has spoken that pain management is an important component, and why should you, take it away from a patient? Why should the patient have to bear the pain? But there are beliefs regarding patients getting addicted to painkillers. And some of the caregivers or family members are concerned that because of these painkillers, the patients are not themselves. They are in a state by which, in a different state, they're not in their normal states. They're either drowsy or they're delirious. Are these concerns valid and real? What could be the best pain management outcome? Pain management treatment, so that the quality of life could be maintained.
Actually, it all depends upon actually the type of cancer and the type, what is the level of pain. You have actually graded system of pain management. And problem with hepatocellular carcinoma is actually the little bit different actually. Sometimes they present with us with encephalopathy. They will be little bit drowsy from the because of the encephalopathy part. And at that time we must be very cautious about using sedations or morphine like that. But it all depends upon the pain level of pain actually, and the making the patient more comfortable. The actually what happens the here is actually where you can do something, where you cannot do something. If you can do something, it is all actually it's from the starting from the surgery, transplantation, and liver directed therapy, targeted therapy, immunotherapy, whatever it is. If you don't do something, it is like Barcelona stage D patients or child classification C. When I usually liver is there is actually we have to see the good quality of life, which is actually the what we have to do is only to maintain the quality of life. And what we do, we have to be because of encephalopathy part is there, and sometimes it's very difficult. What is the best painkiller and how much painkiller you have to give? If you give more painkiller, if you are developing encephalopathy, you cannot understand if they are developing encephalopathy or not. That's you have to see. And sometimes we involve the palliative care specialist. Actually, there are some pain management specialists, and we involve them from the beginning. Actually.
Right. Dr. Shikande, in the resectable cases post-surgery, what is the chance that the patient may have a relapse or may have the cancer coming back? Is this a worry for patients?
Yeah, because we are basically dealing with a bad cancer. Let's not forget that cancers of the liver have happened predominantly in livers which are already affected with many years of insult. The insult has been either of alcohol or hepatitis B or hepatitis C. It rarely does liver cancer develop in a normal, healthy liver. So there has been a lot of insult which the body takes for a long time, and therefore these cancers are more aggressive. And though we might operate and remove the tumor, the liver environment is already an unhealthy environment because of which the tumor happened the first time. So even though we cut it out, there would be about 60% chance that within 5 years of such an operation, the tumors will come back. So we also have to counsel these patients that the tumors are being removed with a desire to give you a chance of a cure. But the chance of a cure is between 30 to 40% when we remove the tumor completely and it is localized in one place in the liver. And despite that, you might have a 60% chance that any time in the next 5 years, in 6 months, in 1 year, in 1.5 years, in 2 years, in 3 years, in 4 years, in 5 years, you will get 6 patients out of 10 in whom the cancer may come back either in the remaining liver or in the lungs or in the bone or elsewhere. So this is because inherently we are dealing with an aggressive cancer. But still, we also need to give them the confidence that in 4 out of 10, they're going to live long with a good quality of life. So these are the real concerns. So after the operation is done and tumor is completely out, giving them the confidence to have a good quality of life, keeping in touch with a good surgeon as well as a medical oncologist for further treatment, as well as a gastroenterologist and hepatologist has to continue, because we have to manage the remaining liver, maintain a good quality of life, and keep a close follow-up. Because in a small proportion of patients, we might detect a problem on follow-up, which also now we are able to treat by a combination of surgery or liver-directed therapy or chemotherapy or targeted therapy, etc.
So the follow-up is quite important, Dr. Advani. Dr. Advani, one of you also mentioned, I think Dr. Srikhande mentioned that if the patient has a hepatitis, reason for the cancer, then we have to reduce the viral load before we go ahead with whatever treatment is planned. Now, during this time, doesn't the cancer spread? Then doesn't it become harder to treat the cancer if you are already treating the virus which is impacting the liver?
So it's a clear answer that you have the house on fire with more than one problem to deal with. So you try to deal a liver cancer in a patient who has a bad active hepatitis. The patient is not going to withstand the anti-cancer treatment because the liver is in a dangerously bad situation. So people need to understand that we are not choosing one over the other, and we are not ignoring the cancer. We are choosing to do the cancer in a later stage in order to ensure that they get a chance to get good treatment. So one is the scientific reason why we first have to treat the liver well and then treat the cancer. Now, the other worry is that people say the cancer in that meanwhile will spread and go out of hand. That's where you also need to tell them it's not simple life philosophy, but it's also oncology philosophy. And oncology philosophy is that we are educated individual doctors with expertise, but we are not gods. So there would be a percentage of some percentage, not a large percentage, where during the time that we bring the liver hepatitis under control, the cancer stays quiet, and then the cancer responds to anti-cancer treatment better because the hepatitis is under control. So that confidence building, that counseling is a combination of science and your heart, and that will bring about good results. I don't know what Dr. Advani feels about what I'm saying.
No, I think that's very correct. You have to, this question is always asked, not only in liver, but many other conditions.
Exactly.
We always prioritize. See, ultimately, when you are giving the treatment, you cannot just say that this is a disease, I'm going to eliminate it, and at the same time, something else kills a person. So you have to prioritize that what is the situation that you can treat first, and the second part which can give you some time. So I think you have to balance it out.
But Dr. Advani, Dr. Srikhande has explained to us the oncologist's logic to treat, the virus condition first. Does this lead to better outcomes of the cancer treatment? Can you say that conclusively, or is that also a chance?
No. That is always definitely there. The better outcome means that if you, with the active virus, if you operate, I'm sure Dr. Srikhande will be in a better, you have a disaster waiting for you.
I mean, this is well-proven science of many years. This is not something new. This is not modern. You need to, as I said, if the fire is at multiple places, do not expect a quick fix remedy.
Mm.
If you have a patient who is old, if you have a patient who is diabetic, if you have somebody who is drinking alcohol for last 40 years and then has got uncontrolled hepatitis, then the rest of your anti-cancer treatments are not going to work. As compared to someone who is more disciplined, the hepatitis is not there, the diabetes is not there, the quality of the liver is good, they will respond much better. This has been shown in enough of scientific data for the last 2-3 decades now.
Dr. Mahapatra, I just wanted to check with you anecdotally. Does liver cancer happen more with males? And because alcohol abuse may lead to cirrhosis of the liver. There are a lot of things that play on the minds of patients. One is the emotional issue, one is the health issue, one is the financial issue as well. And many men are just addicted to their alcohol as well. So, in your practice, have you seen more men diagnosed with liver cancer, and what kind of counseling do they require for these issues like addiction or financial stress?
Actually, what we are seeing more of a male actually, and the counseling part actually, what they have a lot of things to ask us actually. So one is actually, we see different type now. Actually, previously we used to see more of a hepatitis related. Now we are seeing more liver disease and liver cancer non-hepatitis related, like obesity, diabetic, and patient non and alcohol related. But when I still we are seeing more patients who are not hepatitis, not alcoholic, they are actually what we tell when more of a obesity, diabetic, fatty liver, which is going to have the liver damage and the cancer. And the counseling part of the different people are different actually. It's all depends upon what is the cause actually. This is always common in a cancer patient. Why it's me? Why it's not to other people's? And so that's the first thing we have to explain why it is me. And second is actually depends upon the patient actually, how we get the patient. If somebody is active, they can have a active treatment possible, and they don't have the financial implication. We encourage them to go out to the job, but we tell them not to use the, if there is addiction, to stop the addiction, and we tell them how to stop, or if required we take the specialist advice for that. And that is the thing actually.
Dr. Pani, all of you also spoke about how important follow-ups are. Now, say a liver patient is in a state where he has not been able to undergo surgery and is taking cancer treatment, the therapies and the targeted treatment. If there is any deterioration in his quality of life, will it only come about in a follow-up? What should caregivers be watchful of, to figure out if his condition is deteriorating? Any signs there?
Yeah, I think the most important thing is not only caregiver, but also the patient himself. They have to, we tell them, follow it up. What are the things to be followed? See that how's your appetite. Keep it up normal. Weight loss. Your weight loss, you have to be concerned about it. And if there's an unexplained fever, the fever goes on, and it is not explained. You have to check that. So basically, it's a sort of deterioration in general. This a liver when it is affected. It's a general deterioration which can happen. So if the general deterioration is there, you have to come. And
Right.
also, mind you, we don't probably sometimes emphasize too much on it, except maybe those who have undergone surgery and there's a chance to do the resurgery. That's a different thing. Otherwise, we don't have many options in medical treatment. So, really, follow up is quite relaxed follow up, and you don't have to make the patient very afraid of it. So we tell them that fine. I mean, there's never an emergency about follow up. You come after 2 months, 3 months, 4 months. So that's our way. You cannot also produce a fear in the patient's mind. If this something happened, you rush. There's nothing rushing by rushing over here,
Mm.
and the patient is deteriorating. You're not achieving something.
Mm.
That's a very important.
So it's important not to panic, but seek your
Absolutely,
doctor's help.
absolutely.
I wanted to check with you, Dr. Mahapatra. You said all of you have underscored that if there is an underlying liver disease, it has to be treated before we, start treating the cancer. But what I want to understand from you, if somebody has a cirrhotic liver, does it mean he will develop a cancer? I mean, what are the chances of him developing a cancer?
See, in a cirrhosis liver, it is always there is a chance because of actually the what happens in the liver cirrhosis. Actually, there is a lot of inflammation, and because of the genetical and epigenetical changes, there always have a chance of developing cancer. Actually, exact percentage I cannot tell, but what happens in actually we as a oncologist patient, cirrhosis patient doesn't come to us actually. So they reviews different places. Actually, we don't have a real guidelines to detect the liver cancer. mane, because where the liver cancers are common like Japan, South Korea, they have a national guidelines of doing ultrasound every 6 months and alpha beta protein, and their detection rate is much earlier where you can treat the patient actually. And we don't have actually what we see patient, they have a cirrhosis, and after cirrhosis they are being treated for cirrhosis, and they present with a deterioration of cirrhosis with a very advanced liver cancer.
Mm. Right. So, Dr. Advani, do you think that there should be a screening program, especially for those who are high risk? I mean, those who have too much of alcohol or had a history of hepatitis, battling hepatitis disease, say they haven't moved, cancer has not been detected. Should there be proper screening, and what could the screening be like?
Yeah, I think for the highly predisposed people because of the either hepatitis C or hepatitis B or people who are alcoholic, they have to be screened in the sense that at least do the alpha fetoprotein and the ultrasound, which are quite simple, and you can detect the disease in early. So I think these are the guidelines which are put up over there.
Mm,
They are not
mm,
generalized. Everybody need not do that. But for those who are predisposed,
mm,
and of course the patients who has got the cirrhosis of liver established, they have
mm.
to have these
Screenings.
investigation done every 6 months or a year.
Right. Dr. Srikandi, we have a mixed panel of experts today. We have you who, you do the surgeries, and we have medical oncologist also. So the entire journey of a liver cancer patient who has to undergo the multifold treatment, surgery if it is possible, then, targeted therapy, or, the chemotherapy or radiotherapy. Um, when patients have to go through this, what is the message that you want to give on how to manage expectations? What can they actually expect if they are going to go through this journey of treatment?
I think it's very clear. You need to be realistic, and yet you need to be optimistic. It's very important that you understand the social framework within which this country functions and the way our people function. There are some patients who want all the information firsthand, and they rather hear it from the doctor. And there are some people who are in denial, whose structure is made differently, where the key would be to not actually tell all the bad news to the patient, but to tell the family. This is not something which is possible if you are abroad. But in India, this is very much an acceptable concept, that you don't kill the hopes of the patient, but you very clearly tell the family as to what the journey is going to be. That's the first step. The second step is, as an expert, you clearly know, is this going to be a situation where we are talking of cure? Are we talking of control? And are we talking of pure palliation and a sense of helplessness from the first patient visit? For example, an advanced liver cancer, stage 4, less than 3 months of life expectancy. There is no point in discussing at length with them about curative treatment approaches and liver transplant and surgery and chemotherapy and targeted therapy. No use. They really need to understand what is best supportive care, how you can take care of that, and how you can help them. But on the other hand, if there is a curative approach, then I think it's very clear you take them through the whole journey first as to what they will expect. The interdisciplinary care meetings involved. Before surgery, do we need to do things like transarterial chemoembolization, known as TACE? You can consider giving transarterial radioembolization, known as TARE. Sometimes you might have to use interventional radiology techniques like microwave ablation, MWA, or something known as radio frequency ablation. So there are combination of liver directed therapies which may be used in conjunction with surgery, or may be used for recurrent disease after surgery, or may be used as a bridge to surgery. That's one step. They might side by side have to continue taking treatment for the quality of their liver, or even to keep the tumor in check while they are undergoing, waiting to get their surgery done, or even after the surgery has been done. So they need timelines in terms of how long is the whole spectrum of treatment going to take. They need an assessment of costs as to what are they getting into and what is the advantage of spending X amount of money for what benefit. So they need to understand the risk benefit ratio of why we are offering and what we are offering. They need to understand how many visits they need to make to the doctor. They need to understand how often do they need to go to a specialist center like Tata Memorial, or whether they are happy with the local doctor and whether we can help them in their local circumstances. Because I firmly believe a doctor close to home should be the best doctor in an ideal world. So all these things have to be discussed with them in the first 1 or 2 visits for them to have a realistic idea. Plus, they need to understand that what would be their quality of life. While doing all this, if the quality of life is going to be meaningful and worthwhile, we have patients who go on following up, who go on taking liver directed and other forms of treatment and carry on for months and years, including multiple visits to a place like Tata, and it's all worth it for their quality of life and length of life. So I think it's has to be individualized to every patient and their family.
Right. We have Dr. Lalit Mohit Sharma also joining us at this point in time. Dr. Sharma, we have discussed a lot about the care of liver cancer patients, and Dr. Shikhande is saying that you have to explain the entire journey to them. Now, say that a patient is in a state to be given curative treatment where he's undergone surgery uh, to maintain his quality of life. How important it is to give him the treatment closer to his home. How often would he have to present himself at multi-center, multi-disciplinary cancer centers?
Yeah, I think that is very relevant, and thank you so much, Dr. Srikhande. Of course, I joined little late, but the multidisciplinary approach remains key to success. At my center, we have palliative care team, we have a surgical team, radiation team, nutritionists. So we get involved many of them before taking any cancer-directed treatment decisions. And many times we take decision when not to treat, how much to treat. All these are important aspects. But of course, we always lack that the facilities and the kind of approach the Acumen Tata Hospital and team is having. We always feel that the same should be available to most of our patients. Unfortunately, in real life situation, we don't get people like Dr. Shailesh Srikhande with us. But in whatever way, limited way, we all try to do that quality of life issues. One important aspect remains even for diagnostic, like the image guided biopsies and image guided procedures, sometimes procedure like TACE and TARE, all those are not easily available in most of the B and C class cities. So we all sort of unite and we all take help from each other. And now since the virtual platforms are available, so I think more and more case-based discussions can be done, which we do on a non-formal basis on our WhatsApp group and sometimes in open forms also.
Right. Dr. Mohapatra, like Dr. Srikhande was saying that, we give them the care they need, the immediate surgery and the post-surgery and pre-surgery treatment is given to them. But it'll be better if the ongoing treatments can be closer at home. Is this possible for liver cancer patients, or do they have to keep coming to the cancer center repeatedly?
Personally, it's all depends upon what is the treatment actually they're getting. If it is when in liver cancer, actually, if you are doing a liver directed therapy, they can get followed up at a local place and they come back, because the side effects of the liver directed therapy will be immediate. After that, there will be no side effects. Only thing you have to monitor the disease progression or the liver. And second is, what as a medical oncologist we using for liver cancer. What we use actually, more of a targeted therapies actually. They are actually, they have a lot of side effects actually, and sometimes the when a targeted therapy side effect of the drugs are more toxic than the disease itself. So as a medical oncologist or anybody, our duty is to explain them about the side effects. What we tell, this will be the side effects, and if you have the side effect, you first stop the drug and contact us. And they usually, whatever happens, we tell them. It is very difficult to tell it, because in also Libeside or TMH Mumbai, if you also in Calcutta or Bhubaneswar, any places, not all patients are from the city actually. They come from the remote villages.
Yes.
Yeah. And what we do actually, we tell them to better to explain the patient, educate the patient, and tell them to stop the drugs, and then they contact us and we tell them what to do actually, and if required we tell them to visit us.
Right. Dr. Advani, for patients who come typically with liver cancer, what is the years that they survive, and what is their quality of life like?
I say that apart from the surgery, where there's a good chance of cure, those patients who come who are not operable, overall outlook is really very poor. Whatever the progress that has happened in last 30, 40 years in all the treatment, it has not really made a huge difference. It's not that incurable liver cancer has become curable. That has not happened. But there's a little progress. Now we know previously whatever few tablets we had, they used to have, we never saw the risk. Now we have a new targeted therapy called lanvitinib, where we are able to see some reduction and some sort of response. Similarly, now we have a immunotherapy which we are using for the liver cancer. Again we see, but all this treatment has not produced cure. It cannot cure. It's all, I would say, it's a palliative treatment. It gives them a good palliation for some time. That is what we are able to achieve. So there is nothing dramatic about the liver cancer treatment that has happened apart from the surgery.
Right. Dr. Sharma, then what should you tell your patients if they do come at a stage with which Dr. Srikhande told us that, surgery is only possible around 20 to 25% cases, and the remaining cannot undergo surgery, and most probably they will not have a curative treatment. So how do you prepare them for how long they live and how they will live?
Yeah, that is very, very common practical question which we come across in our clinical practice. And commonly we tell them that surgery is the best available option, and we take opinion from surgeons, in fact, in whatever stage one comes. and we make sure that the surgeon also gives them in writing that this is not operable currently. And then we start them treatment, and we try to counsel them that your disease cannot be cured, but we will try to control the disease. About the remaining part of life, which most of our patients are asking us how much the time is left over, we do not commit, in fact, honestly. I tell them that usually it may be few months, but sometimes people may survive for years also. It all becomes difficult, in fact, what sort of treatment modalities we use and how one responds to that treatment. Like Professor Advani is here with us, who has been teacher of most of us, in fact. So he also keeps guiding us that never tell patient that we don't have treatment for you. And we have one or another treatment available, and more drugs are available. But of course, it comes from which background the patient is coming. Socioeconomic status is most important in my clinical practice. And we take care that people who are coming from, say, low socioeconomic status, we hardly discuss the immunotherapy and other all modern therapies. And few drugs have got some support system available, like lenvatinib has got some support system. And now, since it is being manufactured by few of the Indian companies, so now it becomes more affordable also.
Right. So we're going to wrap up the show now. We come to the end, and I'll give the last word to Dr. Srikhande. Dr. Srikhande, when patients do come to you with a liver cancer, and whatever stage they may be in, if they can be operated upon, what is it that you tell them about the quality of life? And do you tell them that you can live so many years at all? Is there any science to that? Is there any statistical proof to that, or is it varies from patient to patient?
Of course, it varies from patient to patient, and you can't convert the patient's mind into a doctor's mind to tell them exactly what will happen in an individual patient. But is there pooled data? Is there documented data? Is there scientific evidence? Why am I offering a life-threatening surgery and a complex surgery where I'm going to invest half a day in operating on a patient if I don't see any benefit? So I'm convinced that offering surgery, which is complex surgery, if it's going to make them live long, it's justified. Now, to which patient I will tell them that you have a 40% chance to live long and you have a 70% chance to live long is very individual to that individual patient, their level of awareness, their level of involvement, their desire to know more about it. But to somebody or the other, either the patient and his or her family or only the family, they will always be in details. My consultations, despite being in Tata Memorial, last for about 20 to 30 minutes in patients who undergo surgery, because they need to have a comprehensive idea of costs, complications, realistic expectations, everything. So I think we give them enough confidence. And those patients who do well, and there is a large number of them, they are the ones who also take the message clearly beyond my scientific publications that patients who deserve surgery should get surgery. And even if they don't get surgery, we have better avenues to prolong the length of their life with a good quality of life. So we all clearly, all the experts on this panel, we all work together without a doubt for the benefit of the patient ultimately.
All right, most definitely all of you are putting in a lot of efforts to ensure that patients who come to you with liver cancer have a good quality of life, and whatever means you have to improve their quality of life, you do deploy. Thank you so much to all of you for joining us today. I know it's very busy time for doctors, and for you to take out the time to come on the show so that people are aware of liver cancer, the treatment of liver cancer, the outcomes and the quality of life will really help a lot of people out there. Those perhaps who are in high risk would consider screening, on their own to ensure that they do not develop end-stage liver cancer, and it can be detected early. Thank you so much for joining us today.
Thank you.
Thank you. Bye-bye.